محمود، أصوات الطبيعة عندك خلابة وين؟
ايه اصوات معلش.
لا بسيطة، في عصافير وكذا، حلو يعني.
هو انا فاتح جنبي كمان محلات وحاجات زي كده، ففي اصوات بقى بتطلع كمان اللي هي الدي جي والحاجات زي كده.
مش غلط، مش غلط.
متهيألي يا دكتور احنا يعني ممكن نبدأ.
ممكن نبدأ إن شاء الله. طيب تمام. إيه طيب يا جماعة، إن شاء الله هاي second session اللي راح نعملها for virtual internal medicine rounds. Um, I'm just gonna give brief, let's call them ground rules, or just an introduction. Basically, we spoke last time about trying as much as possible to keep the entire room in English so that everybody gets used to English expression in a clinical setting, in a medical setting. If anybody has any questions about English, or if anybody cannot speak English very well, we will help you out. It's okay if you want to participate in Arabic if you can't participate in English. And basically, the way we're going to conduct this is we've come up with a case, and the case is going to be acute abdominal pain. And then you're going to act as a first year internal medicine resident, and you're going to try to talk to a patient with acute abdominal pain who's presenting in an emergency department. You're going to take their history, do a physical examination, and basically decide on what labs, what studies you're going to conduct. And then based on that, you're going to come up with an assessment and plan. And then towards the end of this session, we're going to try as much as possible to present this case the same way that you will present it when you are a resident in the future in a clinical setting. And as we go along, of course, we'll take some time to discuss our progress and discuss the best way of conducting ourselves within this uh, setting or within this experiment. I would urge everybody here to please bring a pen and a piece of paper and write everything down. And this will help you out when it comes, when the time to present comes. It's very important to write everything down. We stressed this last time, and we will continue to stress this every time. Write everything down, because you will forget and you will be disorganized if you're not writing things down. And I suggest that as you take your notes, you take your notes on a piece of paper, and you have a separate piece of paper in which you organize your notes so that they're ready for presentation. Okay, so we'll start. So I'm gonna say what the case is, or what the scenario is, and then we'll leave room for the audience to raise their hands if they want to participate. They can get we can get them in the speaker section, and then we can start conducting the case. So basically, the scenario is you are a first year internal medicine resident, and the emergency department calls you. The ED physician says that they have a patient with uh, acute abdominal pain that is severe, 8 out of 10, associated with a couple of episodes of vomiting, and the patient is tachycardic, and they have had this abdominal pain for more than 4 hours now, and they want you to admit this patient. They have done a complete blood count, a CBC, which has shown that the patient has a white blood cell count of 18,000, which is slightly elevated. A hemoglobin count that is normal, within normal range. He had a hemoglobin count of 13.5, and a platelet count of 400,000. The patient also, they also did a complete metabolic panel, or a CMP, that showed basically that the patient's kidney function was their creatinine was 1.5, and their BUN was 27. And other than that, it was unremarkable. Potassium, sodium were within normal range. Um, so basically, this is the information that you get from the emergency doctor, and you're going to go to the emergency room. You're going to ask your history questions, and I'm going to act as a patient. So please, people, raise your hands, and let's get this started. Anybody? All right, we got our first couple of people. Okay, Dr. Mohammed.
Hey, hello. I just want
Uh,
to ask about some basic information. I think we just missed that. The age of the patient and the sex of the patient.
all right. So I did not give you that information because the ED physician didn't give you
All
that
right.
information. So
Okay. Okay. All
you're
right.
gonna take it from a patient. Yes.
Okay. Hello.
All right. Hi.
Hey, this is Dr. Mohamed Babers. I'm from the internal medicine team. I'd like to ask you some questions.
All right, Dr. Mohammed.
Okay. How may I address you? What's your name?
My name is Bara.
Bara. Hey, Bara. How are you?
I'm good. Thank you. I'm having this abdominal pain.
Oh, okay. So we're gonna check that out. How old are you, Bara?
I'm 62 years old.
Okay, 62 years old. All right. I would like to ask you about this pain.
Mhm.
Where's this pain? Like, where is it in your belly? Like, which part does it hurt the most?
It's 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 right in the top of my belly, right under my rib cage. It's
Okay,
it's
right.
really it's really
Is it
hurting.
okay? Is it in the middle or is it to one side?
It, it's right in the middle there, right in the middle. Sometimes
Okay.
goes to the right, sometimes goes to the left, but it's really kind of right in the middle there. Sometimes goes to my back too.
All right. So okay. So it started. You said it 4 hours ago.
It started, yeah, a little bit more than 4 hours.
Okay. So did you feel this pain like before, like yesterday or any time before? Do you have any past episodes of this pain?
I've had indigestion before. I've had heartburn before, but nothing like this. Nothing even close to this.
All right. So did it start this severe, or did it get worse with time?
Well, it when it started, it was severe, but not this severe. It's just it
Okay,
started, it was really bad, and it's just gotten
and
worse
got
since then.
worse. I see. I see. So okay. So you said it travels to your back. Does it travel any place else? Any place else on your belly and your chest, and your?
No, no, it just it's right there in the middle, and as I said, sometimes goes to the left a little bit, sometimes goes to the right a little bit, sometimes goes to my back, but it's mostly in this middle upper part of my abdomen.
Okay, I see. Okay. Does anything? Did you notice that anything makes the pain worse? When you, like, let's say when
Well,
you. Okay.
I noticed that eating, when I eat I just feel really bad. So I
Hmm.
haven't had anything to eat since this whole thing started, and I haven't had anything to drink either. I tried, and I just started vomiting. I couldn't
Oh,
keep
I see.
anything in, and
I see. Okay.
maybe lying down on
Any,
my back
anything?
maybe made it worse a little bit.
Okay, yeah, that's what I was about to ask. So lying down your back makes it better. Anything else makes it better?
Well, lying down on my back made it worse a little bit, not better.
Oh, okay. So anything makes it better. Like, let's say if you lean forward, does that make it better?
Nothing really works.
Okay. All right. Okay. So you told the ED physician that you vomited 2 times.
Yes.
Okay. How much was that? Like, can you describe how many
Just very
shots was that?
just exactly what I had to eat and drink right before.
All right. Any blood in the vomit?
No.
Okay. Was that vomit preceded by like? Did you feel like you want to vomit, or was it out all out of a sudden you vomited, or do you feel nauseous before you vomited?
I just as soon as I ate the food, it just came right back up.
Okay. Just last question in this section. Do you have any fever yesterday or today? Do you feel any chills, or did you feel like you're very cold and you need to wear
No,
more clothes than usual?
no, no.
All right. I'm satisfied with this section.
All right, Mohammed. We're gonna give room to Shadi.
Okay. Yeah, that's great.
Hello, everyone. My name is Shadi, and I'm a first year internal medicine intern. So, hello, Mister. I would like to address you a couple of more questions in addition to Mohammed.
Mhm.
So, please, can you characterize your pain? How is it a burning pain or is it
It's
a
really
stabbing pain?
sharp, stabbing type of pain. It's just like somebody's hacking at me with a knife.
Mm-hmm. And it was worsened during these 4 hours?
Yeah, yeah. It's gotten worse.
Uh, 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 do you have any chest pain? Any,
No, no, not really. It's just in that middle area.
so it is most likely radiating to your back, right?
It does sometimes. It does go to my back. I feel it sometimes.
Do you have do you have any change in your bowel movement, like diarrhea?
No, no, I haven't had any diarrhea. No.
No diarrhea. So,
Hmm.
and are you taking any medication today?
Wasn't out of food.
Oh,
Yeah.
okay. Do you have any shortness of breath?
I'm feeling a little bit. When I take a very deep breath, I feel discomfort in my belly. I feel like the pain is a little worse, but I don't feel short of breath. No.
Oh, okay. Um, do you have any other complaints other than this abdominal pain? Would you like to address us?
Well, I have a little bit of a headache. It's not really too bad, but I'm kind of having a little bit of a headache, and I'm really
And
thirsty. I'm really thirsty.
I can see that. Did you have any prior episodes before this time?
No, no, I've never had this before.
Oh, okay.
Right. Um, Anybody else has any history questions?
I want to ask, can you hear me, Dr. Bara?
Yes, yes.
Yes. I want to ask about the context to which you got the pain. Was you doing any activity or just resting and watch TV or what exactly?
Well, no, I was just sitting on a couch and watching TV and drinking a few beers.
Yeah, so you were just taking some pills before the onset of the pain, right?
Yeah, like any day I was watching the game and drinking beer and eating chips.
Yeah. Did you take any medications today?
Well, I'm supposed to be taking blood pressure medications, but to be honest, I haven't been taking those.
So in today or the last few days, you didn't take any medications, right?
I haven't really been taking my medications now. Do you have any medications in particular that you're thinking of?
Like pain medication or headache medication,
Like what?
Panadol, paracetamol, or like aspirin.
Well, I have used paracetamol or Tylenol, they call it here. I
Yeah.
have used Tylenol, but I haven't used any aspirin or ibuprofen or Motrin or anything like that.
Okay. You have you been hospitalized for any episode like this before, or this is the first time?
No, no, no. I've never had a pain like this before. I've had indigestion, I've had heartburn, but nothing like this.
Yeah, you take any medication before, like antacids or proton pump inhibitor for your indigestion?
Well, yeah, in the past I took some antacids when I had indigestion, but they never worked, so I didn't take any this time.
Okay. I guess I'm satisfied with this section now.
All right. Anybody else in the audience? There are a lot of other questions to ask. Come on, guys. Be
We're still
brave.
in the
Go for
HPI.
it.
We're still in the HPI section, Dr. Bara, right?
Yes, yes. So you can continue. You can ask about the other sections, but sometimes we can take a brief pause here and talk a little bit about those sections, HPI and past medical history and medication history and all that. So Mahmoud, for example, thought it was pertinent to ask a few questions about medications now. You do not have to stick to that order, which is HPI, before you ask about medication history or before you ask about past medical history or social history. Some of these things can be supremely pertinent and you need to ask about in the HPI. So again, when we think about presentation of a disease, while you're taking your history, you need to be thinking in your head, what's the differential diagnosis, and ask questions that could rule in or out every differential diagnosis. So when we think about abdominal pain, we're going to think about the differential diagnoses of abdominal pain. So you guys have done a great job so far. You've asked multiple questions that were very relevant. You asked about fever, diarrhea, nausea and vomiting, and those can help you, rule in or out something like viral or bacterial gastroenteritis. However, nobody asked questions, for example, in this particular area about abnormal food. If I ate food, for example, from a food stand or something like this, that might result in food poisoning, or if anybody around me in the family had similar presentation, because if somebody has gastroenteritis, the fecal oral route can result in transmission of people in the same household. So these are questions that are good to ask in a situation like this when you're considering the diagnosis of gastroenteritis, whether that was viral or bacterial. So that would be one of the differential diagnoses. Other differential diagnoses include peptic ulcer disease, for example. So peptic ulcer disease, I think Mahmoud was trying to get at that when he was asking about medications and pain medications, but we're mostly actually not thinking about paracetamol or Tylenol. We're actually thinking about NSAIDs. So you want to ask the patient if they've been taking ibuprofen or if they've been taking naproxen or if they've been taking any of these over-the-counter NSAIDs. And most patients will, if you ask them what medication are you taking, they will not tell you the over-the-counter medications that they're taking. They will consider that you are asking about prescription medications, which means that the medications that their doctors have prescribed for them. So you need to specifically ask about over-the-counter medications that the patients are taking, because they basically consider those as a supplement. And a lot of the time you have to ask about supplements if the patient is actually taking supplements, because people don't consider those to be medications. So we talked about gastroenteritis. We talked about peptic ulcer disease. I see Muhammad joined us, so I'm going to give room to Muhammad to ask any additional questions if he has some.
Yeah, thank you. My first question actually is on a scale of 1 to 10, 10 being the worst, how would you rate this pain, the stabbing pain?
It's just 8 to 10. It kind of, goes between here and there.
Okay. In addition to that, any other associated symptoms besides the nausea and the vomiting that came with the onset of the stabbing pain?
It's just been that nausea and vomiting. And this really bad pain. Other than that, I feel like maybe I'm getting a little jittery. I'm feeling like, but that's pretty much it. And maybe that little headache. but that's it.
Okay. And in regards to the onset of the pain, is there a particular time of day this takes place?
It's just started 4 hours ago. It's
And,
not,
okay.
and it's been here ever since. It hasn't gone away.
Okay, and I do recall that you did mention that you said you were laying down drinking a couple of beers, watching TV. But anything else you could happen to remember that you were doing in the past 4 hours, whenever the pain or the onset of the pain started?
No, I think that's just it. I think I was watching the game and drinking beer and eating chips.
Uh-huh, uh-huh. Okay. Let's see here. Yeah, I think that covers everything for me for the HPI besides the other questions that were asked.
All right. Shukran, Muhammad. So basically, there's still a lot of differential diagnoses. I picked abdominal pain in particular because this is one of the things that uh, at least to me, when I was a resident, I felt like one of the most challenging things is abdominal pain. The abdominal cavity has so many organs, and everything can go wrong. So you need to think about all the possible differential diagnoses. We've talked about peptic ulcer disease. We've talked about um, uh, uh, gastroenteritis. We have to rule out one of the things that people will tell you. The first things that you have to rule out with somebody with epigastric abdominal pain is the referred
Pancreatitis.
pain. Sorry.
Maybe we should rule out pancreatitis. You mean?
So
MI.
And
pancreatitis
the cardiac cause.
is a great differential diagnosis, but you have to rule out an inferior MI. So an inferior myocardial infarction. Patients with an inferior myocardial infarction can present with epigastric abdominal pain. It's very important to ask all the questions about cardiac history. Have you ever had a heart attack? Past medical history that could predispose them, smoking, diabetes, chronic kidney disease. This guy is 62 years old. Sure, he's not 65, but still, above the age of 55, he's at high risk of coronary artery disease. You have to ask questions about smoking history, and you have to ask questions about history of diabetes, history of chronic kidney disease, and family history of coronary artery disease, and past history of coronary artery disease, or chest pain or angina or anything like that. So the patient does have history of hypertension, which might put him also at a bit of a higher risk for that. So it's important to ask these questions. Now, the answers to these questions, if we assume that we already asked them, is that the patient is a smoker, does not have history of diabetes, has never had history of coronary artery disease, has never had heart attacks in the past, does not have angina, and does not have family history of coronary artery disease. So this is one of the differential diagnoses that we absolutely need to rule out. Now, other differential diagnoses can be related to, I like to think about things anatomically, so think about what can happen in the abdominal cavity. So we talked about the stomach with peptic ulcer disease, and we can talk a bit maybe about some other disorders, like, say, rare disorders in the small intestine can be acute mesenteric ischemia. And in these patients, you expect them to have history of atrial fibrillation or something like that. So if you asked about history of heart disease and a patient doesn't have it, history of palpitations, patient doesn't have it, you can basically rule this out because it's extremely rare. And if the patient doesn't have those, they likely don't have it. Other causes can be related to the colon. We talked about gastroenteritis that can be, can present as colitis. Multiple bacteria can cause this. And basically you rule this out by ruling out that the patient has diarrhea. So for example, if the patient said that he had diarrhea, you're more likely to focus more on that area. Other things that can cause this is ischemic colitis. And ischemic colitis, for example, the typical presentation for it would be an elderly patient with history of peripheral artery disease or coronary artery disease that will result in narrowing of their mesenteric vessels in the same mechanism that they develop peripheral artery disease or coronary artery disease. And then what happens is they develop diarrhea, and the diarrhea results in them getting dehydrated a little bit. So with the combination of dehydration, in addition to the narrowing already there in the mesentery, they end up with decreased perfusion to their colon, resulting in ischemic colitis. They develop abdominal pain, as well as they develop bleeding, rectal bleeding. And then we can consider other organs in the abdominal cavity. The liver, for example, you have to think about hepatitis. And I know we usually say that these patients have pain in the right upper quadrant, or when we talk about gallbladder disorders like cholecystitis, we think about the right upper quadrant. But all of these patients can present with epigastric pain. And do not expect patients to be very typical, because they will not be. A lot of the patients with, for example, peptic ulcer disease can have pain in the left upper quadrant or the right upper quadrant, not necessarily epigastric. And same thing with those other disorders like acute cholecystitis, or, for example, acute hepatitis like hepatitis A infection or something like that. So it's important to ask questions about, a history of liver disease, or if the patient, for example, has a presentation of hepatitis A, jaundice, diarrhea, anything like that. And you guys asked about fever already. Acute cholecystitis also is a different possibility. You could ask about the risk factors for it. The patient is not female, but you can, for example, ask about weight. Usually this information is given to you, but when you see the patient, you can see it, but that's something that you can ask about. And in addition to that, you can ask about, I think the most important question is going to be, have you ever had, or first of all, do you still have your gallbladder? Because a lot of patients by the age of 62 have gotten their gallbladder taken out. And then the second question will be, do you have history of stones in your gallbladder? And then the other differential diagnosis can include acute appendicitis, for example. And although this usually happens in a younger age, it can still happen at any age. And it's something that you should keep in mind. And with this particular disorder, the presentation starts with middle abdominal pain. So, and then it starts periumbilical, and then it moves basically in the right lower quadrant position. Other differential diagnoses include diverticulitis, and this is very important also. You can ask about this. Does not result in diarrhea, but it does result in abdominal pain, fever. So very important differential diagnosis also to rule out. And then other differential diagnoses, like Shadi and Mahmoud were saying, is acute pancreatitis, which is basically what kind of questions, let's ask this, what kind of questions would you ask to rule in or out acute pancreatitis? Anybody?
We would ask where the pain is traveling. So most likely patients with acute presentation would have the pain traveling to their back. And it is very severe. It would be like 10 out of 10 and very stabbing and sharp. And we would have a clinical presentation of nausea and vomiting due to the distress that the patient is having. Also, we can ask about previous episode. Maybe the patient is having a recurrent pancreatitis, so an alcoholic history would be a good question to check if the patient had any recurrent episodes. And like knowing his age, and he's 62, and he's most likely, like he has a great probability to have it. So I don't know if we could add anything else.
All right, so that's really, really good. You touched on very important points. So you talked very well about the presentation of acute pancreatitis, and again, you touched on this, but it's great to kind of explain this to everybody else. Is that when we talk about any disease, there are two things that we need to keep in mind. The clinical presentation, which is basically how the patient comes to you, and then the background, because most diseases have a background. For example, when we talk about cardiac disease, the background, it's going to be risk factors for cardiac disease, history of smoking, family history of cardiac disease, all that kind of stuff. In pancreatitis, we're going to talk about a background of maybe alcohol use or a background of maybe history of gallstones, because the most common differential diagnoses or etiologies of acute pancreatitis are going to be alcohol and gallstone pancreatitis. So these are very important differentials to rule out. And as you said, past episodes of pancreatitis are very important because patients who have one episode of pancreatitis are at an incredibly higher risk of developing another episode. And there are a lot of different disorders that can put you at risk of developing recurrent acute pancreatitis. And if you've had enough episodes, you can develop basically chronic pancreatitis, and have this chronic abdominal pain that is very, very difficult to treat, that we can possibly have a different room discussing that by itself. So I think Bisan just joined. Mohammed, did you want to say something?
Yeah, I just wanted to add one thing. I know that we said that the gallstones and the alcohol are the most important risk factors, but cholecystectomy and does not have any alcohol use history, and I'm still kind of suspecting pancreatitis, I would order a lipid profile for the patient, and would suspect that if the patient's triglycerides are in the thousands, especially if it's like above 1,000. So that's
Great.
kind of a
Great. Hypertriglyceridemic pancreatitis, very important differential as well, especially in patients who are obese, history of diabetes, or family history of lipid disorders. Bisan just joined us. Bisan, if you would like to add anything, or do you have any
Hello.
additional questions?
No questions. I just joined because I want to be part of this discussion. Thank you.
Okay. All right. So basically, to imagine that we ask the questions and answer them. The patient, how would you ask about a alcohol history for this patient?
You'd start off by asking them first what type of alcohol do they consume, beer, wine, liquor, depending on whatever type of alcohol they consume. After that, you ask about how much they consume. Ask them to give you kind of a reference, like a cup, a mug, a glass of wine, and then go into details with that, like how much would you define a glass of wine as, even by just pointing with their hands, how much the size of that is. And then, of course, the frequency, how many times they drink. And yeah, that's about it, I think.
Perfect. Okay, great. So basically, you want to ask about uh, first of all, do they drink alcohol? And if the answer is yes, how often? And then basically, based on that, you can say, okay, what type of alcohol do you drink, and how often do you drink it? And then basically, what you need is to get a feeling of the quantity and the frequency of their alcohol use. So for this patient, he drinks about 12 beers a day. And when the pain started, he was watching TV and drinking beer. Asking about any hard liquor, the patient says that on the weekends he usually drinks a few shots. Uh, all right, so I think we wrapped up the history part, at least the HPI part. Now we're gonna move forward and talk about maybe past medical history, and continue the history part. So anybody wants to take a chance at taking finishing the history?
Yeah, sure. In regards to your past medical history, are you currently seeing anyone for anything?
I'm not seeing any doctors, no.
Okay, do you happen to have any history of thyroid disease?
No history of thyroid disease, no.
Okay, hypertension?
Yes.
Okay, emphysema?
I don't know what that is.
Emphysema is just a kind of like a blood-related disorder.
Yeah, I don't know. I don't know anything about that.
Okay, we could come back to it. It's okay. How
Mhm.
about obstructive sleep apnea?
What's that?
It's like you have difficulty breathing while you sleep, like you try to gasp up for air and wake up in the middle of the night.
Yeah, I don't think this ever happened to me that I wake up in the middle of the night. I usually just
Okay.
sleep and wake up the next day.
Okay. Okay. That's what we like to hear. How about any cancer history?
No history of cancer, no.
Okay. How about any let's see here. How about any arthritis?
I do have some knee pain sometimes, but that's about it.
Okay. Any history of diabetes?
Nope,
Okay. How about stroke?
nope.
All right. Okay. How? Yeah. That's about it that I have for the medical history. And you did mention that you're not seeing any doctor for anything, right?
No, no.
Okay. Not
I
even.
used to see a
Mhm.
doctor for my high blood pressure, but
Okay.
I haven't seen him in like 3 years.
Okay. And is this a family medicine physician, a cardiologist?
It was a one of those free clinics.
Oh, I
Uh,
see.
yeah,
Okay. And I'd like to actually expand on that a little bit, if that's okay with you.
yeah. What's up?
Yeah, sure. So, how many times did you see this doctor for your hypertension?
I don't remember, just a few times.
A few times. Okay. And was there a medication he or she prescribed for your high blood pressure?
He did describe a little yellow pill, but
Okay.
that was about it. Yeah.
Okay. And I'd like to ask a little bit more questions later on here. But are you still currently taking this hypertension medication?
No, I haven't taken it in a while.
You haven't taken it in a while.
Yeah, I didn't
Okay.
feel better when I took it, so I just stopped it.
Yeah, so you weren't really satisfied with that treatment, huh?
No, not really.
Not
I don't
really.
like taking pills.
Yeah, no, I completely understand where you're coming from. Okay. Besides the this free clinic that you attended, do you ever go to any other free clinics for any other reasons on a more of a consistent basis?
Nah,
No. Okay. So like you mentioned, you're not seeing anyone for anything.
nah.
Okay. Okay. All right. Well, that kind of does it for me for the past medical history.
All right, Mohammed, thank you. So your past medical history was very good, very specific. However, it takes a very long time.
Right.
You're doing it the right way, and I probably usually do it the wrong way, but but the way that I would do it is that I ask patients, do you have any medical disorders that I should know about? And if I have a high degree of suspicion for something, I ask about it specifically. Otherwise, I don't. So, for example,
Got
for
it.
this patient, you asked about, and for this patient, for example, because he's a smoker and he has history of alcohol use, significant alcohol use. So I would ask specific questions about these, about cardiac history, for example, and stuff like that. But uh, I would definitely try as much as possible to reduce the amount of medical jargon. So things like obstructive sleep apnea, emphysema, don't ask patients about these. They won't know what you're talking about. So try to ask more of questions in the form of, do you have any lung disease? Have you ever seen any doctors about your lungs? Do you
Right.
have any chronic cough, for example? If you're trying to get a feeling, get a sense of what their history is in terms of, for example, emphysema, and in terms of obstructive sleep apnea. I usually ask about, do you have a partner that tells you that you snore at night? Or, for example, do you feel refreshed in the morning or anything like that? But usually, this is a deep dive into questions related to a disease that is probably not highly contributing here,
Right.
and therefore it's a past medical history. So I would try to keep it brief, and move on to the next point, because you're going to be admitting a lot of patients, you're going to be seeing a lot of patients. However, again, um, you're doing it the right way, being very specific, and all that is a very good thing. If you can find a way to do it quickly, it'll be
Right.
great. And of course, get rid of the medical jargon.
Yeah, I just got to simplify it down for the patient for
Yeah.
sure. Yeah. Yeah.
All right. Anybody else wants to do a quick? We did medication history, surgical history. Nobody has talked about that yet.
Yeah, actually, I wanted to ask about surgical history. Do you have any surgery in your abdomen or pelvis?
I've had an appendectomy back when I was 12 years old. That was a very, very long time ago, though.
Yeah. Did you have any GI studies before?
What does that mean? What's a GI
Uh,
study?
Studies for your gastrointestinal, for your stomach and your intestine. Do you have any studies for this?
What's a study for that? Like,
Uh,
what do you mean?
any investigation? You have any like ultrasound or your doctor order anything for your? You said you have like indigestion. Do you order
Yeah.
any? Do you had
No,
any
they've
investigation?
never they've never given me any imaging or anything like that. I've never had any ultrasounds or anything like that. No.
I wanted also to ask about any illicit drugs you use. Any history?
Well, I have used cocaine in the past, but I stopped.
Yeah. I also wanted to ask about sexual activity. How to Dr. Ba, I
Uh,
want to know how to address this question because if I am concerned about like hepatitis or something like this.
Good. This question in particular, to be honest, I wouldn't ask it right now with this patient's presentation because it's so low on your differential diagnosis. But if you, for example, run your labs and run your tests and it looks like they might have hepatitis, I would go back, find the patient and say that, hey, have you ever been, I would start it out like this. Have you ever been exposed to hepatitis virus? And the patient would say either yes if they know or no if they don't know. And then if they say no, I would say that, there are certain activities that could put you at higher risk, and those include, for example, blood transfusions, tattoos in a certain, era of time that is no longer here, and very soon we're going to stop asking about tattoos. And then you can say that, sexual activity can also increase your risk. And then that would be my entry. So always create a kind of background to this question so you can ask it in a more appropriate way. So the patient feels like, okay, there's a reason why he's asking me about this. And it's not just that he's, I don't know, weird or sick or something.
Okay, yeah, I see. Also,
All right.
I want to ask about did you gain any weight recently?
No, no. I might have lost a few pounds, but that's it.
Yeah, yeah. Okay. Did you feel like your abdomen increase in size or it's like normal? It's the same
Um,
as usual.
it's the
Okay.
same. It's the same.
Do you felt any swelling in your legs?
Nope.
Okay.
So good,
That's
Mahmoud.
it
You're
for me.
asking about the hepatitis and liver disease history. That's good, but we've passed the HPI part, so now we're focusing on the rest of it. So let's skip that. It's important, but then again, the
Okay.
history. Uh, well, it's okay. You can ask. Go for it. I mean, I understand you're probably thinking this is a guy who's abusing alcohol. Maybe he has alcohol cirrhosis, but then again, alcohol
Yeah, yeah.
cirrhosis doesn't usually present with acute abdominal pain, unless you're thinking about SBP or spontaneous bacterial peritonitis, which would be, a different differential diagnosis, probably a different patient who comes in with a different presentation.
Okay. I'm done for now, I guess.
Okay, all right.
Okay,
Okay, so
last couple of questions. I just wanted to ask if you have any drug allergies.
no allergies.
Or okay. The other question is okay. We got the surgical procedures part, so that's what I wanted to ask next. But yeah, that's it. Thank you.
All right. Okay. So let's move on to physical examination. What do you guys want to look at in this patient?
First, we would like to get the vitals.
Okay. So vital signs: patient has a heart rate of 98, and he has a blood pressure of 165 over 110. and he has a temperature of 97 degrees Fahrenheit, and he has a respiratory rate of 16, and I guess, and he's in terms of mental status, he's alert and oriented ×3. All right.
Just besides the vital, I would take a random blood sugar for the patient real quick.
Good. Blood sugar comes back as 82.
Okay. Oh, sorry. And you mentioned that you got a CMP for the patient. I missed that. Sorry. So we could have also looked at that for the glucose.
So this is the orders part, right? We still haven't gotten there.
Oh no. Okay. Yeah, because of the ED physician, you said okay. It's all right. So
okay.
I just wanted to look at the blood sugar, anyways.
Yeah, that's all right. Okay. So it's a good thing to do blood sugar, and you can think of blood sugar as part of the physical examination, because you can get a very quick point of care blood sugar that can help you determine what's going on in a lot of patients. Were this patient younger in age, you could consider diabetic ketoacidosis as a cause of his abdominal pain, and a blood sugar will give you a lot of information about that. So good idea about the blood sugar. Now let's continue with the physical examination. Anyone, guys, please raise your hands. This is a very, very good chance, like we were saying last time, to make the mistakes that you don't want to make as a resident, or you don't want to make when you go for your electives, and you're trying to be as impressive as possible. So this is a great time to make all the mistakes. So please raise your hands. It's going to be beneficial. This is a very safe area. And we won't make anybody uncomfortable in any way. So if you participate now, it's a good chance for you to learn. Okay. Shadi, I think you were trying to...
So I can start by checking the patient's general appearance. Like you said, he's not in acute distress. He's conscious, cooperative, and oriented. So first, I would like to start by a general abdominal examination, because our differential is heading toward an abdominal pathology, and then we can proceed by the other systems.
Okay.
So good. First, I would like to start by general inspection of the patient's abdomen. I would check if he. Okay.
Yeah, let's say that basically, I think we're past the point of you describing exactly what you're doing. So basically, you want to examine the abdomen, and the patient's abdomen is tender on deep palpation, but not on superficial palpation. There is no rebound tenderness, and there is no significant guarding. And the Murphy sign is negative, and that's pretty much it. His tenderness is mostly in the epigastric area.
Okay, doctor. Do we have any abnormal masses on the exam, maybe?
Nope.
Okay. I would like also to auscultate the patient's bowel sounds to check for any hyperactive bowel sounds or hypoactive.
Great. The bowel sounds are decreased in frequency.
Okay. I would like to do the cardiac examination. So I would like to get first measure the rate and rhythm and check for symmetric pulses.
Okay.
For the patients
pulses are symmetric, and the rhythm are regular.
Does he have any normal S1, S2, any murmurs on exam?
No murmurs, normal S1, normal S2.
No pericardial friction rub or anything, right?
Nope.
Okay. Also, I would like to do the lung examination. Does he have good bilateral air entries, any rhonchi, any crackles, any wheezes?
No rhonchi, crackles, wheezes, good air entry bilaterally. Reduced respiratory effort.
Mm-hmm. Do we have any pulsatile abdominal mass that we don't have any pulsatile abdominal mass, maybe?
Nope.
No?
Good question. You're thinking about abdominal aortic aneurysm. Good differential.
Yes, because
good thing to roll out.
he has a hypertensive and smoking history, and I don't know, but
Absolutely.
what is his BMI? I think that he's
BMI
like,
was 35.
so he's obese, so
Yes.
it's a risk factor. We can check for also for femoral pulses. Are they also symmetrical or not? Like to complete the vascular examination.
Yes, good questions. Ruling out peripheral vascular disease. Yes, the pulses are felt bilaterally, and they're strong, same amplitude.
Okay. For the HENT had ear and eyes and neck examination, do we have any abnormalities?
Nope.
No rhinorrhea, no throat infection, no aphthous ulcer, nothing, right?
No.
Okay. So I would like to check, like, because he's a diabetic, for just like to check for
He's
any
not a
peripheral
diabetic.
ulcer. He's not a diabetic, sorry.
No.
Okay, he's not a diabetic. Okay, so, and also I would like to examine uh, uh, his volume status. Does he has decreased skin turgor?
Let's say that yes, he does.
Does he have mucous membrane? Are they dry?
They're dry. Yeah.
Okay, so in this case, I don't know if we could just insert a peripheral IV for the patient. Meanwhile, giving order to start a peripheral IV because he's
Great idea.
dehydrated, and his chorea and urea, they are slightly elevated, but we don't know any kidney disease. Yeah, we didn't ask about any renal history about
No.
him.
Yeah. No history of
We
renal
don't have a
disorders.
previous baseline chorea or urea, right?
Nope. You don't have any baseline labs.
Okay, but I forgot to ask the patient, is he urinating well? Does he feel that he needs the surge to urinate? Maybe if he has
So
a globus sensation, we could insert a catheter. I don't know.
So urinate well. So the patient says that he was urinating fine, but he hasn't had anything to drink in a while, so he hasn't gone to the bathroom since this
Okay.
whole thing started.
Also, I would like to do a digital rectal examination.
Sure. You do a digital rectal examination. It's brown stool.
No fecal impaction, no fecaloma.
Nope.
Okay. I think would do the neuro exam or
So you do a neuro exam and it's normal. The patient is a little jittery. He has a little bit of a tremor, but that's it.
okay. The tremor, like you mean asterixis or not?
Not asterixis, no.
Okay. So I guess that's it for me for the examination. I don't know if any colleague would like to add anything. Thank you.
Yeah, the only thing I would add to that, like that was great, but the only thing I would add, maybe not in this particular patient, but I would look for the hernial orifices if there is any incarcerated hernias or something.
Beautiful, beautiful. No hernias.
Also, I want to check his eye to see if there like any jaundice or something like this.
Nice, great. No jaundice. So great. I think, yeah, go Mahmoud, go for it. Sorry.
Okay, I don't know if they tried to see if the patient has splenomegaly or hepatomegaly to see how palpate the liver and try to see the size.
You can't palpate the liver. You couldn't. You tried and you couldn't.
Okay.
All right. Great job, guys. Really great physical examination. Again, the way I would do this is always start from the top and move to the bottom. Another way you can do this is you can do it system by system, which I think Shadi was kind of going in that direction. But it's easier for me to follow where I'm going if I'm doing it head to toe. So of course you start out with the general description of the patient, general examination of the patient. What do they look like? And then start with the head, eyes, ear, nose, throat, and then move to the neck if it's important to do it, if you're looking for a JVP or something like that. And then you would move to the chest, abdomen, and if you're going to do a genital exam, or in this case, a rectal examination, and then you would look at the extremities, and basically moving in that direction gives you, I feel, at least to me, it makes it very difficult for you to miss anything. All right, so that's good for physical examination. Now we're gonna talk about the lab tests that you guys want to order. So we're gonna limit this as much as possible. So we leave the rest of the orders to the plan part. But if you think of any super pertinent things that you would want to know before you present this to the attending, what would be the tests that you want to get?
EKG, I guess.
Beautiful. That's very, very, very important. So EKG, and what goes with that?
Like heart enzymes, any like
Beautiful. A
see if,
troponin, because
yeah.
it gives you the difference between unstable angina and the myocardial infarction, right? So if you have EKG changes, a new onset chest pain without elevation in liver enzymes, that is considered unstable angina. However, if the cardiac enzymes. However, if the cardiac enzymes are elevated, then that's an MI. It's a depending on the ST, it could be an ST elevation versus an ST depression MI. So very important to get both. We don't get one of them. We always get both. Okay, so EKG, what else?
We can get a CBC.
CBC was already done.
Okay. Okay, yes, we could done. We could order amylase and lipase.
Amylase and lipase, very important. Okay. And
total bilirubin, direct and indirect.
Okay, this is less pertinent. We'll leave it to the plan.
Okay, sorry.
What else?
I would also like to add a serum lactate.
Good, very good. What else?
Maybe a CRP.
Okay, less pertinent. I'm looking for an imaging study. We want a CT scan of the abdomen and pelvis. I think it's super important. Patients with severe abdominal pain, to me, almost always warrants a CT scan of the abdomen and pelvis, because some things you just can't rule out with physical examination. Somebody talked about an abdominal aortic aneurysm. Sure, we talk about a pulsating abdominal mass. I've never seen one of those. And I've seen a few patients with abdominal aortic aneurysms. So a CT scan can pick up on that. A CT scan can pick up on acute pancreatitis. It can pick up on acute hepatitis, can pick up on colitis, can pick up on bowel obstruction. So a lot of things, a lot of information are taken from a CT scan of the abdomen and pelvis. Now, the question is going to be here is, are you going to get CT with contrast or without contrast in this patient?
Well, his creatinine is 1.5 and his BUN is 27. We don't know any idea of his previous baseline creatinine. So I don't know if he is a candidate for giving him a nephrotoxic contrast.
Beautiful. So you're right on the money with that idea, is that, okay, this patient has acute kidney injury. Do I want to give him contrast that might cause him to have worse renal failure? So, this has changed a lot in the recent years. The contrast materials that they give now are a lot less concentrated than they used to be, and therefore they're a lot less nephrotoxic, but you always have to think of this. There is a cutoff in GFR. Off the top of my head, I can't remember exactly what it is, but I think it's 35. However, what I always do is I call radiology, because, again, I don't know what type of contrast they have in stock and which ones they will use, and they will always have more information about the safety of the contrast in the hospital that you're working in. So if I feel like I need a CT scan with contrast, then that's how I would go. In a patient like this, if you're looking for anything that has inflammation, a CT scan with contrast is the way to go, because the contrast will show you where the inflammation is. Without contrast, it's very difficult to diagnose something like acute pancreatitis, for example. And colitis can be very difficult also to be picked up on a CT scan without contrast. You can still find something like an abdominal bowel obstruction or something like that, but it would be ideal if this patient gets a CT scan with contrast. And then in this particular patient, you always also have the chance of given volume resuscitation and then getting a CT scan. So, it's always a discussion. There are no clear, I would say, black and white in these scenarios. You discuss it, you weigh the risks and benefits in every patient, and then you go from there. So now
Doctor?
we're going to go to the assessment and plan.
Doctor, I just wanted to ask to add something. The cutoff, I think I asked one of the radiology residents, and his answer was it was 45. If its GFR is above 45, that's okay. It's below 30, you should not do it. If it's between them, you just give the contrast with a lot of fluids, and it depends on the patient's case. So
Yeah, that's a beautiful way of putting it. And then again, different institutions can have different ways of doing things. So always be sure to know how your institutions deal with it, and in particular the radiology department. All right. Okay, so now we're gonna do the assessment and plan part. Anybody in the audience wants to, take a stab at that, or Bisan, if you want to try. This is usually the most important part of the whole presentation, because it kind of sums things up very well. Your attending might actually stop listening somewhere while you're giving the history and the physical examination and the labs and all that, and start really listening very well when you talk, when you give your assessment and plan. So it's really, really, really important that you have good practice with this, and you be good at summing things up in that particular way. So if anybody wants to try, anybody in the audience, please raise your hand. Again, it's your chance, guys. It's a great chance, I think, to give it a try and see how well you do. All right, I think Shadi is gonna try. Looks like.
Okay, so do
We're
we need to
gonna
order
need a
any other
few.
labs, Dr. Bara?
So I want
Oh,
you to give
just
an assessment and a plan.
okay. So, do you want me to summarize the case?
Yes. So I just want you to give me your assessment and the plan, and then we're gonna have someone present the case.
Okay, so first I would like to admit the patient
But
to
give me
the.
your assessment first.
So this is a case of a 62 like assessment, like you want to summarize in a quick way.
Yes. So basically, 2-liner, 3-liner at most.
So yeah.
That
So
sums
this is a
everything up.
case of 62-year-old smoker known to have hypertension, present and alcoholic, that presented for epigastric pain that started 4 hours ago. The pain is stabbing, radiating, decreases when he lies on his, increases when he lies on his back. Nothing improved the pain. He denies fever, chills, diarrhea, no chest pain, no history of cardiac disease, no cough. The patient denies sick contacts or previous episodes. He's taking. He has no allergies for any medication. Also to note that the patient had an episode of non-bloody vomiting associated with food intake. He has a previous history of appendectomy, and I think these are the pertinent findings of his history.
Okay, so I want you to do this again, but this time what you did now is you presented the case quickly. I want you to give me an assessment. So the assessment is going to be something on the lines of, this is a 62-year-old guy with history of alcohol abuse, comes in with severe acute abdominal pain, and for example, maybe acute kidney injury and tachycardia, with no imaging, for example, so far, or something like that. So basically, just a very quick two-liner to say what the patient has in a very, very quick way. You don't have to
Okay.
mention everything. You try to make it as straightforward as possible, and move towards your maybe 1 to 2, maybe 3 differential diagnoses that you think this guy has. So, for example, in this guy, Shadi, what do you think he has? Let's just put it out there. What do you think he has?
For me, on my top differential, he has acute pancreatitis, knowing his risk
Great.
factor and
What's your
history.
second top differential?
My second top differential is peptic ulcer disease.
Beautiful. Okay, so I would tailor my assessment towards those. So this is a gentleman who has history of alcohol abuse, presents with severe acute abdominal pain for 4 hours duration with nausea and vomiting, consistent with acute pancreatitis versus peptic ulcer disease, although cannot rule out other differential diagnoses. For example, you can do it in this way. But basically, you want to make it very, very, very brief.
Okay, so this is a case of
So let's try.
62-year-old. Okay, so this is a 62-year-old alcoholic male that presented for severe epigastric pain that started 4 hours ago. The patient,
I think, yeah.
yeah,
Go for it. Your voice was cut off for a little bit, but now it's back. Go
okay.
for it.
So the patient is tachycardic. He has we have already a CBC of 18,000 WBCs, and we have 2 differentials to tackle, which is acute pancreatitis and versus peptic ulcer disease, knowing he is presented with vomiting and nausea along with the pain.
Okay, good, better, but still very long. All right, so now we're gonna try to give somebody a chance to present the whole case from start to end. So, anybody in the audience wants to take a try at this? Come on, guys.
Can I quit?
All right, Bisan, awesome. Go for it.
Okay, as far as I follow, a 62 years old male patient, known case of hypertension, alcoholic patient. He presented no other medical illnesses. Presented to the emergency room due to abdominal pain, which started 4 hours before presentation. No radiation of the abdominal pain associated with nausea and vomiting. No similar attacks in the past. He had appendectomy. I couldn't hear when he had it exactly. No history of drug allergy or blood transfusion, and the drug history is for hypertension. The patient take one medication not known by the patient, and no other symptoms. Would you like me to tell the systemic review?
Okay, so I want you to give pertinent negatives, is what we call them, and these are basically the questions that the patient answered no to,
Yeah,
that
I know,
could
but
rule in.
I came late, so I
Oh,
didn't
okay.
hear what they asked. I can do the GI systemic
That's
review.
all right.
Yeah.
That's all right. Then just finish up with the physical examination part, the pertinent labs, and then an assessment and a plan.
Yeah, okay. The physical examination, the patient's vital was blood pressure. I don't know. Also, I wasn't there. And I would tell the temperature
Okay.
and the pulse and respiratory rate. Then I will move to the general examination. I would tell that if the patient is lying flat, comfortably flat in his bed, not in respiratory distress, and no cyanosis, no pallor, no tachypnic if he's not, and no jaundice. Then I would move to the examination of the hands. I would tell if there is any signs of any disease, particularly liver disease like koilonychia, leukonychia, spider nevi, and Dupuytren's contracture. Then I will move to the abdominal examination. The abdomen is, I'm improvising, soft, lax,
So the
with,
abdomen was,
yeah,
it's okay. I'm gonna try and give you some of the stuff so that we get a good
okay.
presentation. So basically, the patient's vitals showed that he was slightly hypertensive.
Mm-hmm.
It also showed that he was tachycardic. His temperature was normal. And then on the physical exam of the abdomen, the patient had tenderness in the epigastric area without rebound tenderness or guarding.
Mm-hmm.
And now you can go on with the rest, which is negative.
Yeah, okay. We have to examine also the back and do PR and examine lower limbs and do the cardiovascular examination.
Okay.
Then I will move to the investigation. The CBC, his white blood cell counts, as I thought that was elevated,
It was
right?
elevated, yes. And his
Yeah.
hemoglobin was
And I
normal,
will
platelet
look
was
for the
normal.
differential of his white blood cells too.
It's mostly neutrophils.
Yeah, uh-huh. Okay, then his hemoglobin would be,
Hemoglobin was normal and platelet count was
yeah,
normal.
platelet count normal. Okay, and I will also look for AST, ALT, amylase.
The AST was normal, ALT was normal,
Mm-hmm.
amylase was elevated.
Yeah, should know how much it is elevated.
Beautiful, very good. So it's more than 3 times the upper limit of normal.
This is like go will let me emphasize the diagnosis of acute pancreatitis.
Hmm.
And I would do the inflammatory markers too. It may help,
So
like the reactive protein.
so this is you jump to the plan part. Now we talked a
Yeah.
little bit about labs, what labs were available, and then now we're going to
Mm-hmm.
continue with the presentation. So we've talked about investigations. Now it's time to give me an assessment and a plan what you want to do.
Okay, the assessment.
Hmm.
Uh, like we said before, a 62 years old male patient, known case of hypertension and alcoholic, presented to ER with severe abdominal pain, started 4 hours prior to presentation, which is mainly in the epigastric region. Uh, his vital, he's tachypnic and tachycardic. His white blood cells elevated, and the amylase is 3 times elevated than normal.
Okay, so again, we're gonna try to make this even briefer than this.
Okay.
I don't want you to give me any information that you've already given me. I want you to
Yeah,
sum
new
things up. So I
things.
want you to do your.
Uh-huh.
Sorry.
Yeah, got it.
So yeah, go for it. Try again.
Well, this male patient, according to his history and examination, may have acute pancreatitis, peptic ulcer, and we are going to do more investigation and imaging for him. Like we are going to make to investigate his inflammatory markers, and we want to,
Okay, so let me. Sorry, we're gonna separate the assessment and the plan.
yeah.
So let me just better, but still it needs practice. So basically, the way I would sum this up is this is a 62-year-old gentleman with past medical history of hypertension and alcohol abuse, presents with severe acute abdominal pain, likely secondary to acute pancreatitis versus peptic ulcer disease versus other diagnoses. And then I would go to my plan. Does that make sense?
Yeah, great.
So this way, you've given everybody all the information that they need about this patient. And then we're going to move to the plan that will end up giving us which diagnosis was the most, which diagnosis is most likely, or which diagnosis the patient actually has if we can get it with absolute certainty.
Right.
So, all right. So the plan part, let's go for that.
Okay, the plan part. First of all, we are going to do more investigation, like
Okay.
to rule out other things too. Like
Mm-hmm.
I want to ask for troponin,
Okay.
CK-MB,
Okay.
C-reactive protein,
Okay.
and now I want to ask for more imaging,
Okay.
like standing abdominal X-ray
Okay.
and CT with contrast.
Okay.
And that's it for now.
Okay. So good plan. So the most important thing that you want to start with is, are you going to admit this patient or not? And where are you going to admit this patient to? So we talked about last time about, this, where does the patient go, ICU versus medical floor? And this patient, do you think is he ICU appropriate, or is he medical floor appropriate, or can you send this patient home?
Can I decide that before like seeing the investigation, and I mean for cardiac enzymes?
So that's good, but right now you're faced with a decision. The ED physician called you to evaluate this patient for possible admission. So you have to decide where the patient goes for now until you finish your workup. So for now, the patient you just saw, the patient that we talked about, where do you think he goes?
He's going to the internal medicine ward, as
Beautiful.
he's stable, hemodynamically stable, and I
Beautiful.
think no need to ICU yet.
Beautiful. These are the exact right words that you're going to say, that you're going to use. This patient, we will admit this patient to the medical floor because he's hemodynamically stable. So you're admitting the patient to the medical floor. That's number one. Number two is, like you said, we're going to look for labs that might rule in or out other differential diagnoses. So we're going to get a CK-MB, a troponin, EKG. I would get an ultrasound of the right upper quadrant to rule out gallstones, to rule out gallstone pancreatitis. I would get a CT scan, like we said, of the abdomen and pelvis. Get lipase. You talked about amylase. However, lipase is much,
Yeah,
much, much more specific
more
to
specific.
pancreatitis.
Yeah,
Exactly. So you want to get lipase, and lipase more than the three times the upper limit of normal.
yeah,
More than that is what is positive for acute pancreatitis. The CT scan will give you most of the things that you need in terms of structure or structural disorders. And then basically you admit the patient to the floor, you watch them with certain vital signs. Now, we are neglecting a very, very, very important thing in this case. And this is something that you will often miss, especially when you go to the US, because it's not commonly done in our part of the world, which is drinking alcohol. This patient has been drinking 12 beers a day, drinks some hard liquor on the weekends. So what kind of different management would you do for this patient when they go in the hospital?
for these patients, I don't know, maybe manage their withdrawal symptoms if there's any withdrawal.
Beautiful, beautiful. So you have to monitor them for withdrawal. This is a patient that has been abusing alcohol. He's likely alcohol dependent. Once he comes in the hospital, he's not going to be drinking alcohol there. So he is very likely to start withdrawing. And you absolutely need to follow them with that. So there are protocols for hospitals here in the US that they use with a scoring system that the nursing staff does every few hours to see if the patient has significant withdrawal symptoms or not. Most hospitals here, all hospitals that I've worked in and the hospitals where my friends work have something called a SIWA protocol, which basically is a scoring system. The nurse goes into the patient's room and they look if the patient's jittery, what's their blood pressure, what's their heart rate, and all that. And that points them in a direction of how badly they're withdrawing. And depending on that scoring system, you might actually have to transfer the patient to the ICU for more intensive care if their withdrawal is so bad. And I've given you guys some indications that the patient is withdrawing because despite the fact that he's dehydrated on physical examination, his blood pressure is very high. His heart rate is also very high, which means that this patient is probably already going through withdrawal. He was jittery on a physical examination, had a little bit of a tremor. This is exactly the kind of presentation that patients with alcohol withdrawal present with. So basically, other than that, I forgot something, and this is to show you guys that if you don't have a pen and paper, you're not writing things down, you will forget about things. I am making that mistake right now. So the patient does have acute kidney injury, and he's dehydrated. Shadi had mentioned to put in a peripheral IV.
Yeah.
You need to order some fluids for this patient. So this patient needs to get some IV
Yeah,
fluid.
sure.
All right. So I unfortunately have to go. I'm actually 30 minutes late for an important appointment at the university.
Okay.
I'm gonna give Dr. Kareem in the audience a chance if he wants to continue with the room without me. Otherwise, we're gonna. Okay, Dr. Kareem, I think he is gonna join us.
Dr. Bara.
Tfadal, Dr. Kareem, do you think you may have the time to?
Yeah, I have some time. I will need from Mahmoud just to recap and go over the case again because I was on a conference.
You're listening on and off.
Yeah, I was on and off, and I didn't catch the entire scenario. So yeah, I mean, if Mahmoud, Chadi, Bisan can give me an overview, and then can go over it from the surgery perspective.
Beautiful. Because acute pancreatitis is kind of those. One of these diagnoses that's a great area, and basically, I think the discussion now would go towards how do you deal with a patient who comes in the hospital with acute alcoholic pancreatitis. I'm sorry, guys. I just have to go. I didn't expect this to take this long, but. I think it was a great discussion, and thank you all for.
Thank you, Dr. Bara.
Thank you. Great discussion. Thank you, sir.
Thank you,
All
Dr.
right.
Bara.
And thanks, Dr. Kareem, in particular, for taking over.
Thank you, sir. Thank you.
All right. Bye-bye.